Hello and good afternoon. I'd like to welcome everyone to the third webinar in our Transition to Transplant series. Today we have Dr. Tanja Gonska with us to speak about liver disease in patients with cystic fibrosis. There will be time at the end of the session for questions, should you have any, and you can either use the raise the hand feature on the WebEx platform, and I can unmute you so you can ask your questions over the phone, or you can type your questions in the Q&A box located on the bottom right of the WebEx screen. Tanja, thank you for joining us today, and I'll pass it over to you to start today's talk.
All right. Hi, Joanna, and whoever joined, I don't see who is actually participating. And all I see is my slides, which I think I have control over now, right? So just to introduce myself, for those who don't know me, I'm an assistant professor at SickKids, where I do work as a staff gastroenterologist and a CF researcher. And I'm cross-appointed to St. Michael's Hospital, where I also consult on other CF patients with GI diseases, including those before and after lung transplantation. So I was asked to give you a little bit an overview of liver diseases and as a diseases in patients with CF, and hopefully, like at the end of the day, that you will also take some practical points out of that. So, Joanna, I tried to click the button, but I don't know how to advance the slides here.
You should be able to use the arrows at the top of the screen.
The arrows at the top of the screen.
Yes.
Well, then I can just make it smaller and then. Oh, yeah, okay, good. I had to go in a different mode. Okay, sorry about this. Mainly when we talk about CF-related liver disease, we talk about the severe end form of progressive liver disease that is developed out of focal biliary fibrosis and then progressing to cirrhosis. And usually that ends up with a really severe picture of hepatobiliary cirrhosis. It's multilobular, and in the consequence, patient develops signs of portal hypertension. And here's some just CT cross-sectional imaging of that. And the prevalence of that severe end of the picture is actually low. And Peter Dury here at SickKids, my mentor, did participate in a really large cohort study, and they found here in Toronto at least only 7% of all CF patients met the criteria of having developed severe CF-related liver disease. And similar in Sydney and Verona, where Kevin Gaskin got together with Verona, they looked at their newborn screening cohort prospectively, and out of 580 screened patients found about prevalence of CF-related liver disease about 6.4%. So it's similar in keeping what we saw in Toronto. We also learned over the years that liver enzymes, ALT and ASTs, are bad marker for the severity of liver disease, as we know they can be fluctuating up and down. So elevated liver enzymes are actually common in CF, and there has been a nice study out of Denver who started early with a newborn screening in 1982 and had a mean follow-up of their cohort of 7 years. And they found that the majority of these patients, or these newborn screened children, had at least at one occasion an abnormal ALT or AST by the age of 20 years of age. And mainly these range between the 1.5, 2-point upper limit of normal. And people now argue, whether that needs to be more elevated to be significant and maybe be useful as a predictive biomarker. They also found that 1/3 of these patients had at least on one occasion an abnormal GGT. The persistent elevation of ALT, AST, or GGT was nevertheless rare, and like I said before, especially in that higher end of the upper limit of normal. So here, there may be like a sign that this could be like maybe a predictive marker in the future if we get more numbers on that. They found in their cohort study that females had a higher risk of ALT elevation, but there was no other association to severity of CF disease by weight, meconium ileus, or severity of mutation. The famous study that could put some light into that severity of CF liver disease was actually done by Peter Dewey here, who was in a consortium looking at modifier genes that would explain why only 7% of all CF patients develop severe liver disease and the others actually don't. And they collected in North America altogether 265 CF liver disease patients, and they combined 2 independent cohorts, and that was published in JAMA. And they found that the median age of the diagnosis was very young, was 11 years. There was a male predominance, and having had meconium ileus was not kind of significant difference between those with or without liver disease. But they do make a point that about 96%, almost all of their patients were those with pancreatic insufficiency and with severe mutation on both alleles. So those only who are really on the severe end spectrum of CF are at risk of developing CF liver disease. As by their own criteria, imaging, there was imaging evidence of 100% of having cirrhosis or splenomegaly as a sign of portal hypertension. Like 3/4 of those patients had actually esophageal varices, and 20% required a liver transplant. This cohort is now being further followed up by Michael Note in North America and his team, and they were still kind of looking at other kind of modifier genes, and they found, and they published that first as an abstract form, and I think it's now a publication, I didn't put it here, that having CF liver disease is actually an early risk factor for CF-related diabetes. And it comes later back again that those with CF liver disease have actually a higher prevalence of CF-related diabetes. So in the original Peter Dewey's cohort, where they kind of put all the data of the severe CF liver disease patients together, and they looked at the age of the diagnosis of severe liver disease, what is striking and what has really changed with the field and thinking is that the occurrence of severe liver disease is early on. So as you see here in the graph, the peak is really between 8 and 12 years of age, and then it kind of fiddled out here in the lower numbers of those recognized or diagnosed with CF liver disease. And you see here that the one-digit numbers when they're older, and they may actually be patients who have not been diagnosed earlier but have been actually missed for a diagnosis of CF liver disease. So 95% are actually below the age of 24. And because this group was interested in looking for modifier genes, they used that group and found that having a Z allele in the alpha-1 antitrypsin gene, which itself in a homozygous status causes liver disease, progressive liver disease, was a risk factor. And similarly, they found a gene variant, a SNP, and a TGF-beta that would be associated with an increased risk of liver disease. So this was like a groundbreaking study, at least characterizing the severe CF liver disease group, and for the first time really laying out that this disease is happening early on in the course of CF disease. The problem now today, and there's very interesting over the last couple of years, has been a reawakening of more research in the field, and I've added some of these publications in this talk today. The problem of diagnosing CF-related liver disease has always been and still is discrepancy in definition. So many people now agree on having really signs of liver cirrhosis and portal hypertension, so going away from this fluctuating liver enzymes, but there's still two different distinct definitions, and mainly between the European and North America. So in Europe, you need at least two of the following. You need a hepatomegaly, liver enzyme abnormalities at 3 consecutive blood works within 12 months. So that's consistent with that chronic kind of elevation of liver enzymes, and or evidence of liver disease or portal hypertension by ultrasound. That's a little bit vague, I would say. North America had defined it a little bit more stricter with the presence of liver cirrhosis and portal hypertension to mark that severe end of liver disease. but then also left an option to have liver involvement by persistent or intermittent liver enzyme elevation, which is similar to the European statement, steatosis, fibrosis, cholangiopathy, and or ultrasound abnormalities. There is currently, for those who are not aware, the infant child study ongoing in North America, the PUSH study, who's first time looking at diagnostic and markers and criteria as well as biomarkers in patient age 3 and an older in a longitudinal way, and to look for the onset of severe liver disease in these patients, and to see at what point do certain markers change, and what can be used to define those with liver disease, and what can be used as biomarkers to predict who will develop liver disease or not. So what happens actually then to those with severe liver disease? What is the outcome? Does it make a difference in that for these patients? And there's been a couple of cohort studies looking at the outcome of patients with severe liver disease. And here was a study on an Australian cohort at a median follow-up of 7 years, 27 patients out of 278. And they found that ascites, or a complication of portal hypertension, was present in 3 of those. Variceal hemorrhage, which is a life-threatening complication when you develop esophageal varices, happened in 2 of those patients. Non-developed encephalopathy, which is like an end stage of chronic liver disease failure. Lung transplantation was prevalent in these 5 when underwent lung transplantation. Non-liver transplantation, and 9 of these patients actually died in the end, but mainly not liver-related, but due to other reasons. There was another study who looked at outcome of patients with CF liver disease and had sex-matched CF controls. And in their cohort, they had 36 patients, and again, a 7-year follow-up. And they found actually that 3 died of these patients. 3 died of liver failure, 1 post-liver transplant, and 3 of pulmonary failure. And they found in their 36 patients, 20 had developed esophageal varices. So that's a little bit of a mixed message. Some of them had developed liver disease complications. And I was lucky enough to find a new study that has been just published here at the Journal of Pediatric Gastroenterology and Nutrition in 2017 from the North American group. And they used the US registry data to look at the outcome of 943 CF patients with liver cirrhosis. And they gave the first time like some more like descriptive numbers that would be worth kind of maybe then following along as the years go by, and then compare maybe with other cohorts, subgroups in the CF cohort. They found that the 10-year cumulative liver transplant rate was about 10%. Liver-related death rate was 7%, here, sorry for the gap here, 7%. But the all-cause mortality, so people dying of not only liver problems, but other complications, CF, in that same cohort was 40%. There's only 7% liver-related death compared to 40% overall kind of cumulative death rate. They did some multivariate analysis, looked at some certain factors, if they can kind of associate certain risk factors to certain outcome. And they found a high rate of variceal bleeding actually in their group, and they associated that in their multivariate analysis to younger age. That was the only risk factor that was left when they put more factors in their analysis. For the risk for liver transplant, which is also a little bit of a controversial point, usually between the Europeans and North Americans being a little bit more reluctant for early liver transplant, having a diagnosis of diabetes or CF-related diabetes increased the risk for the need for liver transplant, and having had variceal bleeding in the past also increased the risk. And that's probably because oftentimes when patients present with a history of variceal bleeding, that may, for some centers, be enough of an indication to say, okay, we do schedule now the liver transplant. Like in Toronto, I know we're a little bit more reluctant to just go by the presence of one variceal bleed. What about liver-related deaths? In their analysis, on a multivariate analysis, it was interestingly only the FEV1 decrease of lung disease actually that was associated with an increase of liver-related deaths. And I think this is all you can get out of registry data. This is not a prospective study, but I think it's somewhat interesting and gives them first-time good numbers into that field. So I was talking about now really the classic severe liver disease, early onset, going into liver cirrhosis, portal hypertension with consequent complication. But interestingly, as our CF population gets older and survives longer and longer, there are now new reports coming out from the adult world talking about maybe a different kind of liver disease to that what I just explained. And the two nice publications, a little bit more, but the two last publication at least, there was from Co and R this year published. He looked at 26 patients who had follow-up for at least a median of 11 years. Some actually said until 38 years until diagnosis. And he started with that from the age of 11 years. And these patients, it was a prospective study, did not have any signs of liver disease at the beginning of the follow-up. And then they looked at the different kind of stages, and then they compared their data from the beginning to the data of the last 2 years of follow-up of this cohort to see what changed. And in that 26 patient group, 11 patients actually died due to various causes, and 2 did die due to liver decompensation. And then they looked at diagnostic criteria using, that was a European study, they had used the DBRAE, the European criteria that I presented earlier on to diagnose a severe liver disease, and they found that 8 patients of that cohort at one point met these criteria, including signs of portal hypertension. But then they looked for kind of different biomarkers, and they looked at new liver disease markers that come out of different liver diseases, such as chronic hepatitis C, for example, or non-fatty alcoholic liver disease, non-alcoholic fatty liver disease. They found that another 17 patients would have been diagnosed with CF liver disease using these new criteria. And they do use modern kind of they do use modern imaging to look at liver disease. One is a fibroscan, one is a transient elastography, and then there are new ways of sorting out liver disease by doing AST to platelet ratios or AST to ALT ratio, or even combining a couple of biomarkers, a blood biomarkers that is for fibrosis 4 index. And when they looked at that, and then looked at the outcome after this follow-up period of last 2 years, they thought that those patients with the newly diagnosed with CF liver disease now, in the end, had higher ALT, AST, prothrombin time, direct bilirubin. The numbers were still in normal range, but altogether this group, compared to those who did not fit the criteria, had a little bit higher numbers. By imaging, by normal ultrasound imaging, there was no difference, but they did find a higher pressure on the fibroscan. And also they found that those with a higher fibroscan, they had higher ALT and AST, and the platelets, which are a common biomarker to assess the severity of liver disease, was lower. And then they found an association between the lower platelets with those then who died of CF liver disease. So that's certainly early on, still a small cohort, but it's interesting saying, you know, like if you use maybe more sensitive marker and maybe somebody, an adult patient who may develop these kind of disease markers later on, there may be a risk for an increased morbidity or mortality in these patients. There was another interesting study from France, actually, showing that you may have liver disease or develop CF liver disease, and this can be non-cirrhotic, and especially in adults. And this center was a single center study. They used their liver transplants that they've done over a decade, and that collected 10 other patients with liver transplant. And the indication actually for that transplant was not liver disease or decompensation, but the risk for liver decompensation post-lung transplant. So these patients were going for lung transplant, and people were worried about, that liver outcome due to liver disease would be good. All these patients had signs of portal hypertension on imaging, and for 9 of these patients, grade 2 to 3 esophageal varices were identified. But interestingly, on histology, only 2 patients showed signs of biliary cirrhosis. That's a severe kind of picture of liver disease. And 5 had just incomplete septal cirrhosis, and 3 had macronodular generation. So I have to show you here a liver picture. I don't know if you remember the first one. So it's not as nodular, as changed, and cirrhotic as you've seen previously. And they found also intrahepatic portal hypertension without the cirrhosis. So they're suggesting, and looking close at the histology, questioning, could there be a different kind of disease pathogenesis in developing liver disease? So rather than what people have thought, CFTR dysfunction leads to like inspissated mucus, bile duct plugging, inflammation, fibrosis, cirrhosis. Could there be like a different pathway saying the way it looks with the portal hypertension without cirrhosis, this could be due to like a venopathy, which would be obliterative, and could be due to all CF patients have an increased post-thrombotic state because of the inflammation, increased platelet activation, or could that be like an inflammatory response secondary to pulmonary or intestinal inflammation? And I thought that's pretty interesting, going back away from that ductal disease to more vasculitis disease as a risk for developing CF liver disease. And that would certainly change our thinking. And I wanted to mention that here because I had a liver transplant surgeon discussing that here at Toronto at one point on a pathology, and he was raising kind of the same idea of this vasculitis. But certainly something that's coming out new, and especially for our adult CF patients, something to watch out in the future. So this is addressed to people or caregivers doing transplantation, lung transplantation. And there has actually been a study led by Nash and Peter Dury, looking at the Toronto cohort and investigating whether the presence of CF liver disease in those patients who undergo sole lung transplantation would change the outcome. And in that kind of large kind of age range, they only identified 6 patients with CF liver disease who underwent lung transplantation, and they matched that with 18 patients, control patients without liver disease. And the investigation showed, when they had compared data before, during, and post-transplant, that there was no difference in the intraoperative procedure or any rate of complication due to the operative procedure. There was no difference in the post-operative course between those with and without CF liver disease. Weight and lung function were the same. Rejection rate was the same. Out of these 6, 1 patient actually developed hepatocellular and venous failure and required transplant for liver and kidney, and 1 patient required a repeated lung transplantation. So small numbers in Toronto, but at least on these 6, there was no risk increase in a bad outcome for lung transplantation, at least. I know that this has been, we had assessed children at least for who had signs of CF liver disease, portal hypertension, and lung transplantation, and there's still the debate whether CF liver disease would increase the risk for bad outcome for lung transplantation or not, despite of the study. And I think it will be still a discussion on an individual basis if you have patients presenting with CF liver disease for lung transplantation. So getting out, what can we get out of all of that? And there's currently still no guidelines or some management guidelines. So I believe, and I'm here at CKIT at least, but also then in the adult world, that you should definitely work up somebody for liver disease if the ALT and the AST on your yearly blood work is up more than 3 times limit of normal. If you have any presence of cholestasis, jaundice, or pruritus, which could be liver, low albumin or increased INR, which are all signs of kind of liver synthesis dysfunction. In these cases, when we do feel that there's a presence of liver disease, no matter if I'm in the CKIT world or St. Mike's, we do recommend workup for other causes of of liver disease, such as viral hepatitis, alpha-1 antitrypsin deficiency, Wilson's disease, and here you did not only do the ceruloplasmin in serum, but we have to actually look for Kaiser-Fleischmann ring with an ophthalmologist. We look for celiac disease, can also have hepatitis on the side, and autoimmune hepatitis. In order to make a diagnosis for CF liver disease, you want to have an ultrasound and particularly look for signs of portal hypertension in liver cirrhosis. Portal hypertension being a splenomegaly, signs of any collaterals, or even sometimes on ultrasound they can give you the idea of perisplema or periesophageal varices. Coming out now with the new kind of findings of adult onset of a different kind of liver disease, I think we should follow up these patients on a regular basis with liver synthesis function testing, albumin, INR, look for development of ascites or risk for esophageal varices bleeding. And if there are these kind of findings, then the debate, should you go for, like, for example, ascites, would a shunting procedure, like going around, that portal hypertension effect, a shunting between the portal systemic circulation, avoid further risk, or would you then indicate a liver transplant? And I know from our point of view here at CKIT and St. Mike's, we are very conservative making indication for liver transplantation. So for monitoring a patient with CF-related liver disease, but like I said, also adult patients where we do not know if they may not later on develop liver disease, maybe non-cirrhotic portal hypertension, I would recommend doing annual liver enzymes, which I think we all do already, but also an INR, PTT, albumin, and also look at the platelets. Platelets may not be insufficient low, like out of normal range, but in some patients who then later on get diagnosed with CF liver disease, you see already the drop over the preceding years. And in the end, platelets have always been a morbidity mortality factor in patients with CF liver disease, so I think that's important. I would recommend to do regular ultrasounds to look for signs of portal hypertension, even in those who have no diagnosis for CF-related liver disease. And I said regular ultrasound because I know that annual ultrasound is probably pushing the envelope, so I leave it up to different centers how frequent that may be feasible or not. And there's currently no guidelines recommending any specific follow-up. And I think in the future, I think FibroScan, although the normal range levels for CF patients are still kind of being explored in the kids world and also in the adult world, I think this is probably certainly a method that will be becoming more and more clinically relevant. So commonly, people going to treatment, if you have diagnosed your patient with CF liver disease, what can you do with that patient? And is there any treatment that you can offer in order to change the outcome? And currently, there's actually not. Like, it would be important to diagnose liver disease in order to consult on complication of variceal bleeding and kind of give a patient the information how to deal, with a situation where he starts vomiting blood and telling them that's an emergency to come in immediately, calling 911. There's always then the monitoring for progression of liver disease and looking at what point should people consider liver transplant or many of these patients actually will actually not require that. But what about medical treatment? And one comes to mind, which is commonly used, is the ursodesoxycholic acid, being very frequently used in diseases, liver diseases other than CF. I know my pediatric colleagues use it very commonly in babies with biliary atresia, but also in adults and children with primary sclerosing cholangitis. So there have been some groups reporting about improved outcome, usually the European groups, older publications, and they mainly tracked ALT and AST that come down when you treat somebody with urso. But as I said before, there may be not good correlation to actually the severity of the liver disease. Dakar from Holland, he did a really nice study. He cannulated the bile duct in CF mice, which is very difficult to do. And when he infused urso in these mice, he actually saw an improved bile flow that he actually measured. So that would be indicative that there is some change in the rheology and the flow of that bile. And if you think this all has to do together with a viscous fluid and bile plugging, that would be probably the physiological solution with the urso. But so far, actually, and I give you two Cochrane values here, there has been no clinical benefit shown in patients with CF liver disease on urso or not. There have been two Cochrane reviews, one in 2014 and one in 2017. 14 included 10 trials. There were no data for long-term outcome. And the conclusion of the Cochrane author suggested there was insufficient evidence to suggest routine use in CF liver disease. There was another Cochrane review just coming out this year. They included, I think, a little bit stricter criteria for inclusion, and they include only 4 trials in the analysis. There were no long-term data on outcome, and the author actually made a comment about the low or very low quality of the evidence, so that's what has been published, and that would be insufficient for routine use of urso in CF. Then there is a study that some of you know about in patients with primary sclerosing cholangitis, or not CF, which is kind of like also a bile duct disease, if you want. And these patients, and this is a progressive disease with usually a bad outcome with requiring liver transplant. And they used high doses in the study cohort, and they showed improvement in the liver enzymes, but the monitoring safety board early terminated the study because there was an increased risk of major adverse events in those who were on urso treatment, and the major adverse event were death or need for liver transplantation, which was actually their primary outcome. There was also a 2009 study. Despite of these kind of caveats and risks that are published out there, I think it's really still common that patients get put on urso, not in Toronto, but in many other CF centers. And I just want to warn you with one more time, that actually comes from my mentor, Peter Dury, who has not managed, unfortunately, to publish these results. It was presented at a CF conference a couple of years ago. We did a mouse study, used wild-type in CF mice, and they usually have intestinal obstruction, so they had to go on a liquid diet once they're weaning. And he randomized these mice to different treatments. He put wild-type mice on urso, actually on no urso or urso, and he put the CF mice on no urso and urso. And then he harvested all the organs. They looked for survival, and they had blinded pathologists to score the inflammation and bile duct obstruction. And there was like a scoring scale similar to what people have previously lost, how many cells are there, how much fibrosis. And interestingly, pathologists, these are blinded pathologists, labeled like here this lower slide as a CF mouse, because he found all that inflammation around the bile duct and bile duct plugging. But in the end, when we de-blinded that slide, it came from a wild-type mouse, so not CF, who was treated with urso and had all the signs of inflammation. And when they looked at the survival analysis, I don't want to bore you with all the details, but that's the survival analysis. showed that CF mice on Urso treatment performed worse than those without Urso treatment, at least warranting the free use of Urso and the feeling of that is all that harmless to provide Urso, acknowledging that mice are not men or men are not mice. There's another point I want to add on, which has gained more and more interest in the recent years and may also contribute to what the adult hepatologists kind of now see as a possibly new CF disease in older patients. And that is that the liver is actually not standing alone here in the body, but there's a close feedback loops between the gut and the liver. And that has been investigated in several liver diseases where they found that microbiome changes may actually impact severity of liver disease or progression. But it's also being now more and more focused in the CF world, where we acknowledge that the intestine of CF patients shows inflammation to different degrees. And with that inflammation, primary or secondary, that there's also a degree of dysbiosis or change in the microbiome. And then the question becomes, can these microbiome changes and maybe also the intestinal inflammation lead to what people call like a leaky gut kind of system, where things can move over tight junctions and then goes through the portal flow into the liver and then cause secondary inflammation in the liver. And there was a nice kind of study out of the group around Markowitz looking at these biomarker for children developing CF liver disease, who found that those who actually did develop liver disease, they had an increased intestinal lesion. So the other one also had intestinal inflammation, but they showed that they had more when they scored these lesions. And they also showed alteration in the fecal microbiome, those with CF liver disease compared to the non-CF liver disease patients. So this is certainly something that people are focused on, and it's certainly gained some interest, because if that is true, then maybe rather than just only focusing on liver disease, looking at the intestine may actually provide some new therapeutic targets. Then I want to almost end, not without kind of saying that there has been, I had not the chance to be there because I was on maternity leave, but there was an international CF liver disease meeting in 2016 in Paris. It was the first of its kind, and invited CF hepatologists, gastroenterologists, but also hepatologists from different areas, and to summarize at least the current status. And in the current status, the document that they published, they recognize that there's a problem with these different definitions of CF liver disease in Europe and North America, and they're aiming now to develop unifying definition in 2017-18, and that would tremendously help future research studies, because then you know that you're talking about the same population. There's a big interest in developing biomarkers or studying biomarkers to see not so much only who develops CF liver disease, who can then be targeted, but then who goes on to develop more progression of the CF liver disease, and in the end, liver failure requiring liver transplant. So they use DGT elevation, has been long in discussion, the AST to platelet ratio, the new markers of mRNA circulating, bile, intestinal bile salts, absorption markers with FGF19 or 4-cholesterol 3-1. So these are things that people do on a research site. They also acknowledge, this group, that preemptive liver transplant in patients with cirrhosis is controversial. So there are some opinions arguing in favor of that, and other opinions arguing against that. There is also the idea of coming up and talking about the CF liver disease pathology. It is really only about defective CFTR and that mechanical inspissated ductal flux and periductal inflammation, or other signaling pathways that are contributing at least to the CF-related liver disease, and that themselves can then maybe be used as a new therapeutic target, which I think is an interesting idea. people coming from other liver diseases look in novel therapy that may also help for CF-related liver disease. There's an altered urso, like ursodesoxycholic acid, that shows an encouraging effect in the primary sclerosing cholangitis group. There should be an F-farnesylate X receptor agonist that stimulates bile acid and bicarbonate secretion, and then a PPR gamma targeted inflammation kind of pathway, and at least in mice has been promising. Well, there's some research ongoing in that field, which I think is interesting to follow. So in concluding, we're coming now from a little bit, trying to summarize what is currently out there. So as a take-home message for your CF patients, I still think that the severe progressive CF-related liver disease is rare and occurs early on in childhood. There's a new entity of CF liver disease that appears to occur in adult patients with the development of portal hypertension. And the question then is that really a new disease entity, or could that be a disease spectrum where early on these children that develop severe liver disease may have just more of that same kind of risk factor earlier on than these adult patients later on. So that would be interesting to follow that story. I would always recommend to carefully evaluate all CF patients for signs of liver disease. And I think this should be done on a regular basis, especially with these kind of new adult kind of recognitions coming along. It should include blood work, ultrasound as an easy form for imaging, and in future probably also fibroscan, which probably gets cheaper and more feasible as time goes on. I think that liver transplantation is rarely indicated, and it's usually also discussed in a team. And currently, though there may be different opinion about this, CF liver disease does not negatively influence outcome of lung transplantation, but again, probably should be discussed on an individual level. So this is all kind of I had to offer for today, and I'm happy to answer any questions.
Thank you so much, Tanja. So I can open the floor up to questions. And again, just to remind you, you can either use the raise the hand feature and I can unmute you so you can ask the question over the phone, or you can use the Q&A box. It should be located on the bottom right of your screen and you can type questions in there. So I'll leave it open. I'm not seeing any questions come through, so I think we'll end the session there. The webinar has been recorded and it will be posted up on the healthcare section of Cystic Fibrosis Canada's website under the Transition to Transplant tab, and that recording will be available in the new year. You can also take a look and see all of the upcoming webinars on our website in that same section, and the registration will be emailed as future webinars are scheduled. So thanks again, Dr. Gonska, and to everyone that attended today's session. Bye.